Thank you for the invitation. And yes, as Dariush said, we're just going to summarize some of the things that I put together in the recorded lectures that Darius has already mentioned. So, of course, we've got to acknowledge that this has been supported by the IAEA, so I just want to put that slide up there. So, these talks are all about quantification, and I thought it was really important to ask the question, why should we quantify? Because if I talk to some of my nuclear medicine physicians and clinical doctors, they will come up with statements like this. They'll say, I can read everything on an image. Visual assessment is perfect for me. And if I'm looking at patients that have been back for a second scan, they'll say, I can see whether the disease is progressed or is in remission. I don't need quantification. I think in some instances there is arguments where really quantification isn't needed, but I think there's a lot of instances where quantification is really quite important. Because we know we can be tricked in all things in life, and you've probably seen these types of images before where you think you're looking at something, but actually the truth is something different. So even in these examples on the left here, the signal is the same in that top left image. The signal is the same, that central bar, but because of the background, it appears to have a different level of uptake if it was nuclear medicine. And similarly, if you look at the images in the bottom left. So even though a signal can be the same, in its surroundings, it may appear to be different. And there are optical illusions as well, of course. This is just one. But of course, our doctors who report our nuclear medicine scans are experts in image interpretation. So I'm pretty confident that they can read round these things, but maybe not always. So I think quantification just gives some reassurance that the signal that they're seeing is at a level that they can be confident in. So I just wanted to remind you of some examples of why I think quantification is important. Again, these were in the recorded lectures. And the images on the left, these are ioflupane SPECT scans, and in the top left, if I get my pointer, is it going to move? You see the images on the left-hand side there where it has normal and abnormal scans. So the normal, you see uptake right through the striated bodies. The abnormal, it's just restricted to uptake in the caudate nuclei, so that's an abnormal scan. And when you get images like this, as I said, the doctor doesn't need quantification. They look at this and they say, great, I can tell you if it's normal or abnormal. But in the cases at the bottom, it's a lot more difficult to interpret. And I think quantification here can be really helpful. And it can bring more consistency in reporting. And what we and others have found is that actually when you have quantification, your newer doctors who report these scans, their performance can match experts if they have quantification available to them. And another example that I put in the recorded slides is, if we wanted to determine disease progression, sometimes we can do these images over various treatment cycles, and we can look at the images and try and make an estimate of whether the disease is progressing or is in remission. But actually, to have quantification, we can really quite nicely follow the treatment success or failure sequentially. And these quantification measures allow us to do this really quite nicely. And we can't do this as well if we're doing this visually. So again, showing why quantification is important.
The final quantification output I want to go through, something that's used quite heavily in neurological imaging, is the Z.
There's a recording on this. I thought I'd taken all the recordings off. Thank you. Sorry. This is another slide I took from the recorded lectures, and that's why you heard my voice in the background there. The other reason why we need to quantify is databases. If we have a number that we quantify on, we can then compare these numbers to normal ranges and get confidence of where the disease is in heart on the left-hand side here and in ioflupane SPECT on the right-hand side. And of course, sometimes we just need quantification. So for those of us who are doing radiopharmaceutical therapy, if we want to do dosimetry, we need to get measurements of activity concentration or activity in our lesions and organs at risk. So thank you. So at this point we desperately need to have quantification, so that it's a no-brainer to have quantification in this instance. So in summary, I think why do we need to quantify? But hopefully I've shown here and also in the lectures that it can help us in so many ways. So hopefully you're convinced now that quantification is of value to us. But I also want to, sorry, my pointer went to, but I also want to say we shouldn't just quantify just because we can. We should be, using it where there's a use case. So many times people develop some forms of quantification, or they do some work, but there's actually not a clinical need for it. So really, we should be using quantification, yes, but only if we see there's value of using it. Okay, so how do we quantify? Well, the requirements for quantitative imaging in nuclear medicine is that we need to have an ability to degrade for the physical effects that our imaging photons undergo, so attenuation, scatter resolution, and dead time. And we also need a sensitivity calibration because, of course, in PET and in SPECT, our outputs are in terms of counts or events and not in activity concentration. This is just rolling forward, so I'll just roll it back again. So yeah, we need to have corrections, and we also need to have a sensitivity calibration because we need to get this conversion of counts and events to activity. I'm talking about absolute quantification here. Of course, in that scan or eye of flu pain example I showed previously, I was just relating the uptake in the region of interest to a non-specific uptake region, and then you don't need the sensitivity calibration because, of course, you're relating the uptake to another region. So just put it out there. The sensitivity calibration is only needed for absolute quantification. And again, for tomographic images, there's usually two ways of doing these calibrations. In SPECT only, sometimes we use a point source or a planar source, and with Siemens they'll give you sources that have a very known or accurate activity, so it you can really have confidence the quantification that you have. And in all PET and in SPECT often as well, we'll calibrate our scanners using a cylindrical source with known activity within that source. So these calibrations are allowing us to get a relationship between the activity that we know we've got in front of our scanners and relating this to the counts and events that our SPECT and PET scanners provide us with. I want to highlight the importance of the radionuclide calibrator when we're doing quantification. I think it's an instrument that sits in the corner of our labs and doesn't get much love and attention. But if we're doing quantification in PET or SPECT, we remember that we're going to do this calibration of our scanner, and the known activity that we measure is going to come from our radionuclide calibrator. So if there are any errors, in our measurements of activity in the calibrator, then that error is going to transfer across to the calibrated scanner. So, it's important to get accurate measurements from our radionuclide calibrators. Ideally, if we can have some measurements traceable to metrology labs, that's great, but we know that that isn't always straightforward, but there are other mechanisms out there to get accurate measurements on your calibrator. So again, just digging deeper here, why is this measurement so important? Well, if you're doing dosimetry on your SPECT scanners, the accuracy of the activity measurement is incredibly important, because if you're measuring the activity that you've got in your kidney, for example, that activity translates directly into dose rate that we're looking at in our dosimetry measurements. So it's critical that you get a very accurate measurement from your radionuclide calibrator so you can calibrate your scanner appropriately. We have to be aware that things aren't always simple when we're imaging things, when we're using radionuclides such as lutetium, yttrium, or iodine-131, and we can get volume and collimator container effects there, so be aware of that. If we're looking in terms of SUV, then it becomes less of an issue, and it's the decay correction between the injection and imaging that's key. Because in SUV, if you recall, I don't know why my thing's folding through here. In SUV, you recall that if our radionuclide calibrator is 10% out, and we measure the activity we give to our patient using that calibrator, and the calibrator is similarly used for our SUV measurements. Sorry, the calibration of our SPECT or PET scanners is done with the same calibrator, then any errors on that one calibrator cancels out because all the measurements are made on the same device, assuming we have linearity. But we know that many of us work in departments where we've got several radionuclide calibrators, so we can't make the assumption of just the one calibrator being used. So even in SUV, SPECT or PET, it's really important that the measurements are comparable and ideally accurate as well. So what are our outputs? Our outputs from quantification is a whole range of things that we have in nuclear medicine that I've put up here. And in this summary, I'm just going to concentrate on a couple of those. And one of those is activity concentration as a metric. So this is looking at our images, drawing a region of interest, and looking at the kilobecquerels per milliliter within that feature. And one of the key uses for this is in dosimetry, either for therapy or diagnostics. And we know that in dosimetry we need to determine the energy imparted in tissue, and the way we do this is we have some information from MERD telling us about the emissions that we get from the radionuclide and the absorption in various tissues, and we multiply that by the activity concentration that we have in that tissue. So it's moves forward. So we're using our scanner calibration to really get that activity concentration in our tissues at each time point and putting that into our MERD calculations. Or alternatively, we don't need to use MERD. We can look at the activity concentration, and we can use things like a dose point kernel, which can convert the activity directly into milligrays per hour in that area. And why do dosimetry? I think there's a lot of debate about why we should do dosimetry in radiopharmaceutical therapy. Well, if we look at our radiotherapy colleagues, we know what we're trying to do in radiotherapy is we want to maximize the dose that we give to the bad stuff, the lymph nodes, the metastases, the tumors, while minimizing the dose that we give to the organs at risk, which here for PSMA radiopharmaceutical therapy of the salivary glands, kidney, and bone marrow. And, I don't think it's good enough, really. It's not good enough to just give 7.4 gigabecquerels of a therapy and just assume that's perfect. It's not. We really should be tailoring these therapies to individual patients. So using dosimetry offers benefits over fixed dose regimens. We're in a privileged position, because if we look at our competitors, if we look at chemotherapy, they give their therapy, then in a few weeks' time, what they do is they then go in and downstream of the therapy look at, with CT or muggers or whatever, looking at the effects, either positive or negative, of that chemotherapy. Where in radiopharmaceutical therapy, we can directly image the therapy at work. We can look at how much dose we're giving to our tumors, metastases, and nodes, and our organs at risk. Of course, there are challenges in that we can maybe get a measurement of dose, and it's not always clear how that dose relates to effect. But I think there's enough evidence out there now to show that there's a strong relationship between the dose these regions, these organs receive, and the effect it has on them. There's guidelines out there for people who want to do radiopharmaceutical therapy. The EANM put a position paper out on Article 56 of the Euratom Directive of 2013. For those of you who aren't aware of that, it specifically says that target volumes should be individually planned, appropriately verified, and doses to non-target volumes should be as low as reasonable. So, it's clear, I think that's quite a clear statement, that we should be doing something to personalize the radiopharmaceutical therapies we give. There's a bit of a disconnect in Europe in particular, but I think internationally is that if you look at the Medicines Directive, it says you've got to do what it says on the prescribing information for these radiopharmaceutical therapies, which is usually standard dosing. So there's a bit of a disconnect between what it says in the Medicines Directive and the Euratom Directive, so this is a bit of a challenge at the moment. We also know that to do dosimetry, although we may wish to do it, it's really quite time-consuming and expensive. You've got to buy software, you've got to find extra time on your scanners, and then you've got to find the people to scan these patients over and over again and also do the dosimetry calculations. So it's not straightforward. And also, I think in the community at large, there's limited knowledge on how to perform dosimetry. And certainly with EFOMP, we're trying to do something here to improve dosimetry training for medical physicists in particular. We should aim to perform dosimetry. Radiotherapy would never treat a patient without doing some dosimetric assessments. The other metric I want to look at is the standardized uptake value, which, as we know as nuclear medicine professionals, is massively used in PET and also now in some SPECT applications. And why do we use this? Well, we use it because the ideal way to do measure uptake is using this thing using kinetic modeling. But kinetic modeling in nuclear medicine is incredibly time-consuming. It requires arterial lines. So what we can do is we can make some assumptions. So I've got a kinetic model up here, and I'm hoping my pointer works now. It does. Is it going to react? Okay, so
There is the delay.
There is a delay, but it's quite a delay.
Keep pressed.
Okay. So what I want to draw your attention to is those at the top of this slide. There's the FDG. Well, let's concentrate on FDG because it's where it's SUV is mostly used. It can either be floating around in plasma, which is C plasma. It can be in tissue but not metabolized, or it can be metabolized within tissue. Okay. Now, if we image 60 minutes post-injection, which is what we do often with FDG imaging, we can assume that any FDG within the tissue is not metabolized. And you see I've got those K values with arrows there. That's looking at the transportation of the FDG between those various states. And equally, we can assume after 60 minutes that any FDG in tissue is going to be metabolized. So if we draw a region around our feature, we can say that we're looking at metabolized FDG. We're looking at glucose metabolism. And so we know that value, when we draw that region around that feature, looking at C metabolized FDG, that is what we're talking about when we're looking at SUV. And it's used for many radiopharmaceuticals now in both PET and SPECT. But we've got to remember, it's just used quite widely, but we've got to remember its assumptions. It's assumptions that when you're imaging, any metabolized radiopharmaceutical is not going to be unmetabolized. You're expecting it to be trapped. That's not always the case. And there's negligible untrapped radiopharmaceutical in the feature at the imaging time point. So we use it in FDG, that's fine. We use it beyond FDG, is that appropriate? Mostly, but I think we have to be a bit more careful there. It's not, we shouldn't just use SUV widely, we need to think about it a bit more. And as we know, how do we do SUV measurements? We'll draw our volume of interest. So what we're doing effectively is looking at the activity concentration in the tissue that we're interested in and dividing that by the amount of activity in the patient generally, or the activity concentration, which is the injected activity, divided by the body habitus. And we typically look at the size of the patient either in terms of weight, but we could look at other ways of normalizing our activity in terms of lean body mass or body surface area. And you know, it's routine to use body weight, but we know that FDG is not metabolized in fat. So for FDG in particular, maybe body weight isn't the best way to normalize. But anyway, that's what people use. But I question whether that's the best feature, the best metric we should use. And of course, we're requiring this calibration of our scanner to get this activity concentration for our image, which we mentioned earlier on about those calibrations. Okay, so as we know, everything in life has its challenges. I just want to pull up some things that, again, was mentioned in the recorded lectures. At every stage of our imaging process and our processing of our nuclear medicine images, we have to take care that we're doing the right things to get a good value of quantifiable value out from it. I'm just going to focus on a few of these. The first one is patient preparation. So we know, again, if you do PET, if you're using FDG, you have to be careful that the blood sugar levels are low enough so the sugar already in the body isn't interfering with the uptake of FDG, so we have to be careful there in preparing the patient appropriately. If you're doing IO-flupain SPECT, some medications will affect the uptake, so if you're quantifying, it's very important to have knowledge of the medications the patient is on. And these are just two examples. There are other examples as well. Of course, when we're doing this quantification, we need to know exactly how much activity we're injecting into the patient, so we need pre- and post-injection measurements. And we need our clocks to be aligned in its timing as well, because you know, if your clock in the clinic is 5 minutes out from the scanner, then all your measurements get messed up. Of course, we measure weight and height if we're doing SUV. And the time of imaging is really important as well. And I want to just draw your attention to the image on the right, where we can see if we image at 60 minutes or 90 minutes post-injection, the level of uptake that we're going to measure, in this case with FDG, are going to be quite different. So, very important if you're doing multiple imaging over various time points that you keep that time consistent so that you measure real change in uptake rather than just change in uptake related to the time of imaging. Okay, I'll just quickly brush through this slide. And when you're acquiring, make sure you get the right pixel and voxel sizes. If you want good quantification, it's sometimes important to disregard the visual image quality a little bit, because if we get good-looking images, they're often a bit blurred or a bit smooth, which degrades our quantification. So we have to be a little bit careful of how we get our measurements for quantification. Sometimes maybe we want to do a different reconstruction, which is a bit noisier but is a bit more accurate. So just be aware of that. And talking about reconstruction, we have challenges here in that the manufacturer really, when they give you the settings for iterative reconstruction, they're focusing on image beautification. They're looking for a beautiful image rather than an accurate image. And for quantification, we're more interested, or we should be more interested in accuracy. And I just want to show this example here. So the image on the top right, you can see if we increase the number of iterations, the value that we get changes. So it's really important to get the converged value with iterative reconstruction, which is going to be close to 100%, rather than getting a beautiful image, which usually stops a bit earlier, but isn't accurate. Things are a bit complicated as well in that convergence is dependent on a number of things, which I mentioned in more detail in my talk. I think I have another bit here as well. So this is just showing that convergence depends on its environment. I've got 2 point sources in this simulation that I've borrowed from Johan Neutz in Belgium. One is a point source in air, and one is a point source with some activity surrounding it. And you can see in the image in the far right there that the speed at which we get the right answer in iterative reconstruction changes with those 2 scenarios. So just be aware of that. But more iterations equals more noise, which is a challenge. And how do we deal with this? There's no easy answer. Averaging over volumes, okay. Maybe a bit of filtering might help. And for those of you who have it available to you, reconstructions like QClear help with getting convergence of your reconstruction, but not getting the image too noisy. The other thing I mentioned briefly is defining volumes of interest, which is quite challenging as well. If you're looking at the uptake in your feature, how do you do it? Do you define it on the CT, which has got better spatial resolution, or on the SPECT, which actually may be better because the volume on the SPECT might be different? The metabolic uptake might not cover the whole anatomical volume. Once you've decided on where you draw the region or the volume, do you draw it manually, which is time-consuming and is variable between various doctors or technologists or physicists, and equally depends on the color scale you're using? Do you use an algorithm? Maybe you do. But those algorithms that often have, they're often not that great. There are other things out there now, and I think for those of you who spend a lot of time defining volumes of interest, artificial intelligence seems to be making a huge impact here, and it tends to be pretty good as well. And I just want to mention again that voxel sizes are a big issue. If you get too big a voxel size, then your volumes that you define are not going to be appropriate. And I just want to talk a little bit about partial volume effect as well, which is a big challenge, because we know in PET and in SPECT our spatial resolution is not as good as we'd like. And that gives us a problem. So in this graphic on the left here, you see if we have this object that's 10 millimeters wide, because of a spatial resolution effect, we're going to get a reduced uptake that we're measuring, and also the uptake spills out of the region as well. So this is a big problem for us. And just show you in this graphic here, and again we go in more detail in the recorded lecture, in that top line we show, of the figure on the right, we have this box, that's the truth, and the one next to it shows that what we actually measure because of the limited spatial resolution, which is obviously reduced and more spread out. And for a smaller object, if we move to the right again, you see a similar effect. And of course, not that we look at cold objects very often in nuclear medicine, but again, it's still an effect that in the bottom of that graphic, if we see the true image, which is a large white box, but the measured image is going to be compromised because of our limited spatial resolution. And there's ways we can get around this, and one of the clearest ways is we image this phantom on the right. Oh, we look at, jump forward again. I'm trying to go back. That's why it helps if I press the right button. So we look at that phantom on the right, and we look at the different size objects. We look at how well they're resolved in terms of activity concentration, which you see, which you see on the curve on the left. So we can apply these corrections by looking at the size of the object and how much we've recovered. And really, any object less than 2.5 times the spatial resolution of the system will be affected by partial volume. So it really affects many of the things we measure in SPECT and in PET. The other partial volume effect is if we have a voxel and it contains different tissue types, So what happens then, I've highlighted in the 2 gray squares. Let's see if I can get the pointer working. You get that gray level of uptake either because you've got 2 homogeneous tissue types when we zoom in, which obviously you get an average on, or at the bottom of that bottom right there, you see that if we have heterogeneous tissue, again, we're going to get an average, which is going to give us a gray level of uptake there. So, yeah, just be aware of that. And we can try and move on. And say choosing the correct voxel size is important here. If we choose too big a voxel, we get more of these challenges. But we can correct for these as things as well. So the first one we said about using the phantom, but for these different tissue types, what we do is just wait for this to proceed. If we're lucky enough to have some data from MR, for example, we can segment and we can try and put the counts back into the feature. Or if we know the spatial resolution of the system, we can try and deconvolve our image that we measure and say, okay, we know this is blurred by this much, and undo that blurring caused by the system to try and put the counts back in the right place. And as I said, the other way to do it is here, as we mentioned earlier. If we image our phantom, we can look at what signal we're measuring because of our limited resolution, and then apply a factor to give us the true activity concentration. And I think hopefully with all these challenges, you see that harmonization is really helpful because there's so many things that can affect the quantification of our images. So if I measure an SUV and you measure an SUV, hopefully we're measuring the same thing. But because of these variability, all these different factors, with harmonization, we hopefully can measure the same uptake. Or if we're looking at dosimetry, hopefully the dose that I measure is equivalent to the dose that you measure. And harmonization allows us to do these things. Just try and forward on. And you'll be aware there's a number of harmonization bodies in Europe and beyond that will help you do this. I just want to come to an end now on this final part of the summary, talking about some of the contemporary hardware that we've got available to us and some of the advantages that gives us. And one of the things, of course, in SPECT is these CZT systems that we're seeing, either for cardiac systems or using a dual detector system in the middle, or in the far right we have one of these exotic finger detector SPECT systems. And why have we moved to semiconductors? Why do this? Well, there's a number of reasons. The scintillation detector that we have in traditional SPECT scanners, they're big, they're bulky, they don't have particularly good energy resolution. Where if we move to semiconductor detectors, we can be more innovative in design and we can get improved energy resolution. And that energy resolution will help remove some of the scattered photons that we get in our image and therefore improve our image quality. These semiconductor detectors also have better count rate performance, so we can scan at higher activities. And some examples here I'm just giving, but the clear one that we know about really is cadmium zinc telluride, CZT, which is found to be the most advantageous in a clinical setting at the moment. Just quickly how these things work, it's relatively straightforward. The left of the image here, you have a gamma or an X photon. It hits the semiconductor. An ionization with the semiconductor creates these electrons and holes. The electrons are negatively charged, the holes are positively charged. So if we have electrons at either side of the semiconductor, we can collect this charge and get a signal. And the great advantage of this over a scintillation detector, the standard one we see in SPECT, is we're directly measuring the signal. That interaction of the gamma photon goes directly to a signal, which gives us great efficiencies. And the reason this offers an advantage to us, I just want to come to the sensitivity of our traditional SPECT scanners. If we're doing dosimetry or we're doing SUV SPECT even, we might want to image the patient from their eyes to their thighs. which is standard for PET. We want to do the same in dosimetry and SPECT as well. But in SPECT, we cover one bed position in 40 centimeters. And because we have a collimator on our SPECT system, the sensitivity is really quite low compared to PET, which means that for each bed position, we could be spending between 15 or 40 minutes doing a one-bed SPECT position. So this is very difficult if we want to do multiple, if we want to do an eyes-to-thigh scanning. It means it's a lot of time of scanning, and which, of course, is very difficult for the patient, but also for the scheduling in the clinic as well. And what makes things worse, of course, is if we're doing dosimetry, we have to do this multiple times as well. So it's not just an hour and a half of scanning at one time point, it's at several time points. And, this is where one of the advantages of CZT comes in. If I can move my slide, is we're seeing with these innovative scanner designs, in particular, if I can move, the finger detector systems that you see on the left-hand side, that we're getting reported increases in sensitivity that allow more than 50% reduction in scan time. So if you're doing a post-lutetium therapy scan, which might have taken an hour and a half, we're getting about an hour, we're doing those in about 30 minutes now with these systems because of the innovative design of these systems. There's some challenges with these CZT systems. They do have energy limitations for photon energies above 200 keV, which affects lutetium and iodine. But people are working on solutions, so I suspect this is a short-term challenge in using this technology. And then finally, just talk about PET MRI. PET MR obviously gives advantages in that it really brings synergy. We know that MR is brilliant at anatomy, and nuclear medicine's great at looking at molecular signals or metabolic signals. So the overlap of PET and MR is a real huge benefit. We're getting the best then of anatomy and molecular signals. So if I just move on, and this was all made possible by removing the photomultiplier tube that we get in traditional PET systems and replacing it by a semiconductor. Sorry, this is forwarding on too quick. So the scintillation crystal is still on the top, but we've now got the semiconductors sitting underneath rather than the photomultiplier tubes, which are not affected by a large magnetic field that you get in an MR scanner, which means you've got they work properly, you get positional information that's accurate. I'm going to move on a slide. So we're calling this, we're reading out the light from the scintillation crystal. Originally we used avalanche photodiodes, which were compact and insensitive to high magnetic fields, but they had lower gains than photomultiplier tubes, and we couldn't do time-of-flight PET on them. So now we've moved over to these silicon photomultipliers, which can run at much higher count rates. They're working in Geiger mode. They have much better gain, much better signal to noise, and we can now do time-of-flight PET in these silicon photomultiplier PET-MR systems, so a huge gain. And why am I mentioning this technology? How does it help us with quantification? Well, I think it helps us deal with some of the limitations of PET. We know that PET has relatively poor spatial resolution. We know it has relatively long scan times, which are prone to motion. And if we're doing dynamic imaging, we know that has its challenges as well. So PET-MR can help us with all of these things. So this is something one of our PhD students did a few years ago now. In the reconstruction of the PET data, he was using the MR data to inform the PET reconstruction. And if you look at that top image and you look at the very right of the graphic there, the generative results, you can see that actually they're really very good and not very different from the image at the far left, which is where it starts, the truth in this simulation. And Stefano also looked at putting motion in as well into the reconstruction. You can take motion information from your MR by doing some fast MR, and then you can put this motion information into your into your PET reconstruction as well. So this is clearly an area where MR can help PET. And we'd mentioned about the spatial resolution before. Again, this is some work that one of our team did, where they're using the MR data, and using this MR data, they were able to improve the spatial resolution of the PET. So they're putting the PET signal back into the appropriate tissues using the MR information. Another thing we do a lot in PET is kinetic modeling, and if you're doing kinetic modeling, as we've said previously, you need arterial lines ideally, but many of us are trying to use the image itself to look at the input function. So in this example, again, another one of our PhD students now works for Siemens. We were looking at the input function from the carotid artery, but there's huge issues with partial volume effects here. So we were applying a partial volume correction on the input function to get us a very good input function for our kinetic modeling in the brain. And yet another one of our PhD students, so this is now looking at respiratory motion. So what Richard did is he got a motion model from the breathing of a patient when they'd relaxed on the scanner, and he could then use that motion model taken from MR to improve and motion correct the PET signal. And you can see, just where the mouse is, the pointer is in the bottom right there, you see a much better improvement in the resolution of the signal. And of course, coming back to quantification, all those corrections, of course, help with your quantification, but we also have the advantage of multiparametric imaging, and this is one of the first things we did in our PET-MR for epileptic surgery, where we could look at the PET signal to look at where the epileptic focus was, and then use fMRI to look at where the surgical resection in that area would affect function, and also tractography to see if it was going to give a surgical approach to that part of the brain. And final slide here was some work happening a lot in Germany, and what they've done here with PET-MR is they've done diffusion imaging, and they've on a voxel basis, they define the ADC from the diffusion imaging, they look at the SUV on a voxel basis, and then they put it into 4 categories of high SUV, high ADC, etc., etc. Then they can start categorizing the tissue, and I think this is really quite an exciting approach. And at that point, I would like to thank you for listening. Thank you.